CMS, Medicare anyway, the Medicare part of CMS is a single payer. It pays for the care of people over 65. Hundreds of thousands of nursing home patients were getting advanced antipsychotics, which calms them down. It's kind of like a chemical restraint. But we outlawed restraints in nursing homes as inhuman, but we didn't outlaw chemical restraints, and they were widely being used. When I got that report, I got a little bit exercised, and I remember I called key leaders in the nursing home industry, the head of the For-Profit Nursing Home Association, the Not-for-Profits, Geriatric Society, and so on. I asked them to come to my office, and they did. First point, which is we were a big payer, so yeah, they wanted to know what was on my mind. It took no time at all for them to get together in my office, and I remember sitting around the table. I said, "Hey guys, here's a report about oversedation of nursing home patients. That's not good medicine. That's not good for people. They get pressure ulcers, aspiration. You need to stop it. And if you don't stop it, I will stop it." In other words, we'll use the Medicare leverage of payment and incentives to really make it important to stop it. That day, they began to launch a national program for reduction of oversedation of nursing home patients, which persists to this day. They did it because it was a single payer who was interested. They knew that I would follow up, and they changed the system.
This is Dr. Chethan Sathya. Thank you for joining us for this exciting episode of Northwell Health's 20-Minute Health Talk. Today, I'm joined by mentor, colleague, Dr. Don Berwick, who is a true heavyweight in the field of public health. He is the former administrator of CMS and the founder and former CEO of the IHI. Don, thank you so much for being here with us.
It's such a pleasure to be with you.
Yeah, and it's amazing to sit down and have this conversation with you. You've inspired so many in the last years around public health. You've been a mentor to so many. What's keeping you busy these days?
Well, quite a lot. I have been very disturbed by what's going on in Washington and the bad direction that I think we're taking in public policy. So I've been involved in that, trying to work with organizations that are trying to restore and preserve proper policy, especially with respect to health and well-being. I also have the pleasure of working on a number of projects with the National Academy of Medicine, which I absolutely love. It's like going to college every day. And I continue to speak and mentor. It's a great time in my life.
Yes, and certainly there's a lot on your plate. Are there some pivotal moments in your career as a clinician?
Yeah, a lot actually. I've talked about errors that I've been involved in. I remember as a young resident, I started in internal medicine and then trained in peds, but a young resident in the intensive care unit, the NICU, I almost killed a baby by mistake. I administered the wrong blood transfusion, and oh man, I still get chills when I remember that night. Baby lived, but that was just luck. I remember seeing a teenage kid who came in to see me with a cough. I treated her, and she died that night, and I still don't know why. So yeah, there were these imprinting of things gone wrong. I would go looking for, equipment in my pediatric unit, and I couldn't find it. It just wasn't there. I was pretty immersed in the day-to-day work of medicine and frustrated that things weren't going well. I wrote about the real sort of a turning point. By then, IHI had started, and I was already in the field. I knew Deming and Joanne and people that do the work. But my wife got seriously ill in 1997, and I was at her bedside for literally weeks, watching care work and not work. I wrote about that in a turning point paper for me called Escape Fire. And although I was already committed to improvement as my career, that suddenly became quite real for me. And I think I'd have to say that was a major turning point for me.
Wow. Yeah, I mean, I've read, a number of those pieces that you've had, and they really resonate, and I think there's so many folks who, until you interact also with the healthcare system, right? I think clinicians have that viewpoint because we're treating patients, but until you as a person or a family interact with the healthcare system, it's easy to look over those things. It seems to me like every person I speak to no matter what socioeconomic bracket you're in, what community you live in, has some frustration with the healthcare system, right? And I think you've said that before in the past when people question, hey, well, will people support a single payer system? Will people support a consolidated way for payers to come together? And you've asked the question, well, is anyone happy with the current system? So I guess I would ask you, I mean, if we're feeling like so many people are already unhappy with the system, what are the barriers to bringing them together in this current initiative that you have?
Well, two or three things. One is they have no platform for coming together.
Mm-hmm.
Still, it's still patient, sort of person by person frustration. We don't have, as they say, sort of a political basis for collective patient and family action. It's not really just patients, it's people, because you may not be a patient yet, but you will be next week. So we haven't forged the alliance that's going to be needed and given it voice.
I want to hear, based on your extensive experience, when you're thinking about redesigning the healthcare system, and if you were to redesign the healthcare system, right, what are the big areas you would want to focus on, and what would that look like? But let's start with, as you mentioned, pricing and payment models. So I've heard you mention too that consolidated payment models or single payer does not mean consolidated care options, right? Because this is also a big, I think, misconception or fear among folks is, are we then moving to a system like Canada, where I'm from, where I can say there is great healthcare, but there's also major issues, right? Are we moving to a system where people here would say, hey, is all care going to be like what people get at the VA hospitals, right? Which is something you hear a lot among the public. They want choice. How do you kind of balance the two?
It's really complicated. So with the fragmented system we have now, it's awfully hard to set an intention. I know, for example, you have worked quite a bit on gun violence. There's a tremendous amount of gain possible. You've shown that to get gun violence under control, the healthcare system could come together, make a plan, say, as a system, we really are going to work on this, and together change the fate of tens of thousands of people every year. We don't do that. The Northwell, your system, has tried to do that and pulled together a wonderful consortium for work, but we should be a consortium all the time on everything. We have, the substance misuse really epidemic, killing thousands of people. Mm-hmm. We have problems with chronic disease care, organizing care for flow. We have problems with proper protection of the well-being of kids in our country. If the healthcare system could come together and say, wait a minute, we've got an agenda, even partial one. This year, it'll be kids and substance misuse. We could do a lot, but we don't have a way to come together. With a consolidated payment system, we could. It doesn't solve it, but it makes it possible to solve it. I'll give you an example that really sticks with me. CMS, Medicare anyway, the Medicare part of CMS is a single payer. Mm-hmm. It pays for the care of people over 65, starting in 1965. And the administrator, like me, is kind of the CEO of the government system that pays for care of elders. Okay, that's single payer. So I remember not long after I arrived as administrator, I got a report from the Inspector General, Dan Levin, who had done a terrific study of medications in nursing homes. And what he discovered was that nursing homes were systematically overusing a certain kind of sedative in nursing home patients. Hundreds of thousands of nursing home patients were getting advanced antipsychotics, which calms them down. It's kind of like a chemical restraint. Well, we outlawed restraints in nursing homes as inhuman, but we didn't outlaw chemical restraints, and they were widely being used. And it was wrong. It's wrong medicine. There's other ways to help distressed elders in nursing homes. When I got that report, I got a little bit exercised, and I remember I called key leaders in the nursing home industry, the head of the For-Profit Nursing Home Association, the not-for-profits, Geriatric Society, and so on. I asked them to come to my office, and they did. First point, which is we were a big payer, so yeah, they wanted to know what was on my mind. It took no time at all for them to get together in my office, and I remember sitting around the table. I said, "Hey guys, here's a report about oversedation of nursing home patients. That's not good medicine. That's not good for people. They get pressure ulcers, aspiration, and they're zonked out. You need to stop it. And if you don't stop it, I will stop it. In other words, we'll use the Medicare leverage of payment and incentives to really make it important to stop it." That day, they began to launch a national program for reduction of oversedation of nursing home patients, which persists to this day. They did it because it was a single payer who was interested. They knew that I would follow up, and and they changed the system. So that was a lesson for me. Imagine if we did that for the things that are distressing patients overall, patient safety problems, which persist, lack of patient-centered care, a lack of proper flow, long waiting times in the emergency room, or gun violence. Boy, we could make a lot of difference. We could call people to task, and we can't do it now with dozens of insurance companies, 5 big ones, but a lot of others competing with each other. They don't get together to set an agenda for improvement of care in the United States. When Tom Frieden, who was heading CDC at the time, came to me with the proposal that we work together to reduce heart attacks and strokes by 1 million using proper science for prevention of heart attacks and strokes, the Secretary Sebelius said, go for it. We did it. We got together. Tom was really the lead, but we were able, in cooperation with CVS and a bunch of other organizations, to say, let's put this at the top of the table. And they did. I'm sorry for carrying on so long, but the point you picked up on is, okay, that's using payment to improve.
Yeah.
But the improvement is changing in delivery. That is, you could pay for the same system, you'll get the same results. But if the system changes now, like it did for the oversedation of nursing home patients, or for the stroke prevention, now you've got patients better off. And that's the redesign piece. That's what my life's been spent on. What new designs of care inside and outside hospitals can yield better results? And the answer is tons of changes have been proven, just not adopted.
Yeah. I mean, listen, I could not agree more. And I've heard you, in so many of your incredible talks also mention, right, this is incentivizing that whole person care, right? Beyond the 4 walls of a hospital, for example. So, I mean, this will incentivize things like improving social determinants of health, housing, food, right? Economic opportunities, because those all play into it. And I think those have played into frustrations across public health. In countless other examples, right? And so this kind of system, this redesign, would actually start to incorporate those elements into overall health.
You bet. And that's not kind of a footnote. That's actually the main note.
Yeah.
We can work hard and should work hard on making, let's say, hospital care safer, more responsive to patients in the hospital, making sure that medication errors go away, talking about response times, access for loved ones to people in the hospital. So there are hospital improvements, but we can improve the heck out of healthcare delivery. We actually wouldn't do that much for health status because, as you said, there are these determinants in society, social determinants of health, that are overwhelmingly more powerful than healthcare itself. I'm for making healthcare perfect, don't get me wrong. But if we really want, fewer heart attacks and strokes, fewer gun violence injuries, better nourished and more alert children, we need to work on those social determinants. For example, early childhood experiences matter a ton. They're the most powerful determinant of overall health status, according to the scientific literature.
Oh yeah.
Better schools, education is a powerful determinant of health status. And when you invest in education, you get better health. Workplace safety, workplace meaning in work, minimum wages, elder care. For example, Vivek Murthy, the prior Surgeon General, had spent years trying to teach us about the harm done by loneliness in elders. If you have social systems to keep elders engaged in society, health status improves. Strangely, it improves both for elders and for general society. Isn't that interesting? And then, of course, the infrastructures in our towns, cities, and rural areas for food security, housing security, environmental improvements, including greenhouse gases, the biggest threat to human health on the planet right now, according to the World Health Organization. Criminal justice reform, compassionate, restorative criminal justice, which exists in many other countries, but not ours. These are determinants of health. When the payer, as it is, say CMS, for example, and the community at large get interested in this, we can move resources properly into helping people stay healthier. That's a change.
Mm-hmm.
Northwell Health has been a kind of leader because, for reasons maybe attributable to Mike Dowling, your prior CEO, I mean, seems willing to engage, but that's the exception. That's not the rule. We could make it the rule, and that would involve big changes.
Yeah. No, I mean that's well said. And there's like this misperception as well. I think that some folks are affected by social determinants of health and others aren't. I would argue every American is in different ways, right? There are always barriers.
No matter what their wealth, by the way.
Yeah, exactly. And I think that's exactly where we started this conversation. Is that's the frustration you hear from Americans here, every day. Everyone has a barrier to accessing care. Almost everybody is unhappy with the healthcare system in some way. And what you're talking about, redesign, can address many of those things, because I think you're speaking to the ripple effects as well of improving health upstream. Does have ripple effects to all of us, and it affects our families. I mean, think about the conversations on social media right now. Mental health among kids. That's an adverse childhood event, right? That's an exposure. These are all part of that ecosystem.
Yeah, another misperception is that somehow focusing on actual generators of health would create a schism, a split between clinicians and patients. That it'd be like clinicians would feel criticized, or patients would. No. We're on the same side of that net. Believe me, patients and clinicians have the same interests in helping improve the determinants of health, while they also give and engage in great health care when they're sick. And a lot of doctors today are very frustrated by the same traps that patients are trapped in. For example, today we know when a for-profit venture capital firm or a private equity firm acquires a hospital or a nursing home or an autism treatment program, which is very common now. More and more, those are being acquired by private equity. Private equity's job is to produce a return for shareholders. It's not to continually improve care. Certainly not to take their own money and put it into social determinants. We know that by data that when private equity acquires healthcare, quality goes down and costs go up. So we're worse off. The commitment to healthcare as a human right and the ownership of that delivery by a financing system that is us, that's the public, it's the government, even though it would be exercised through private entities. I'm not saying hospitals should be nationalized or doctors should all become government employees. No, that may help some, but no. We could have the same actors on delivery just behaving differently, and if we had a system that encouraged and supported investment in what patients and doctors want, which is better health.
And speak a little bit to, this next point. If there's a single payer system, and a lot of those, and now we're talking about whole health, you're talking about addressing social terms of health, we're talking about all the things that you just mentioned, which I do agree with. There's, of course, an overwhelming additional perception that will that lead to actual clinical care being, yes, more equal, but actually worse for swaths of the population that might consider their care opportunities right now, yes, frustrating, but because they're commercially insured, they feel, hey, listen, we at least have a very high quality of care when we're able to get to a prestigious hospital, let's say, right? And not saying that's the right thing, but that is a big perception is, are we going to go backwards with respect to clinical care, innovation, cutting edge therapies? What would you say to that? And how do you think about that in a budgeting process?
Yeah, well, it's hard not to get a bit wonky, but let me explain how I think about it. I could be wrong. I mean, I don't claim to have all the knowledge here, but first, single payer, that is organizing care in a single stream, accountable to the public, is not what people call socialized medicine. It's not. It doesn't mean the government then takes over the hospitals and runs healthcare. That might actually be worth considering in some circumstances. We have that with the Veterans Health Administration, which actually has, until the Trump administration has been attacking it so thoroughly, done not a bad job with patients according to the data. The military health system, that's a government-run system. largely. They buy care in the private sector, but they also have military facilities that really set the standard for trauma care, for psychiatric rehabilitation. So it's not necessarily true that if the government is delivering the care, it's worse. In fact, demonstrably, usually it's better. But I'm not talking about that. I'm not advocating for that. I'm advocating for a single government payer, then working with the hospitals and the medical societies and the clinicians and the nurses of the country to make care better. So those who fear that a single payer system will produce worse care, they're not paying attention really to the information. In a single payer system, you get to have a voice that you don't have right now. If you actually think the insurance company is trying to make your care better as its central business strategy, think again.
Yeah,
they are the most. Their profit margins are extraordinary. Profit amounts are extraordinary. They game the billing system. They're spending a lot of energy in advertising. They're paying their executives enormous salaries. Do you think they're using your money to make your care better? Maybe to some degree, but that's not their main agenda right now. The main agenda is to make a profit. That's how the market works. And I want the person sitting at the head of the payment system to be worrying about you, the patient. Number one, every day, spending most of their time talking about what could we do to make care better, not what could we do to make the extra dollar. So maybe people carry around the belief system you're talking about, Chethan. I'm not sure, but if you believe that, you ought to look a little harder at the data.
Yep. Yeah, and you open your eyes to the incredible innovations that are happening across the world.
Interestingly, that includes developing countries. Like I just was in Nigeria,
yes, huge.
Which is, it's a big country. They got a lot of problems, but they know it, and they're smart as blazes, and they're working on innovations in care to kind of get on top of some of the very severe issues that they face. Ghana has done a tremendous piece of work on improving the healthcare of kids under 5. That is it's just terrific. South Africa works on HIV/AIDS care with innovations that we haven't even tried. So, and birthing. There's a project right now in Brazil on safer birthing that has had already phenomenal results. So we can learn from everybody.
In a single payer system, in the way that you're articulating it as well, how do health systems then and practices compete in a way that also continues to push the needle forward on innovation, in offering the best care, in centering patient experience, things like that? Because I did notice a little bit of a difference, right? When I moved from Canada to here, and I love the Canadian system, but when you interact with the Canadian system, right, I have many friends and colleagues who have issues with it. Right. I think there are some redundancies there and inefficiencies, but I am a big supporter of that system overall. When I came here, there's definitely a different outlook when it comes to patient experience, innovations, moving the needle forward on different things. And a lot of that is born out of competition. So in the model you're talking about, that competition still exists.
Well, let's take a couple points there. First, you say that the competition produces innovation. That is an American faith.
Yeah.
That competition leads to better. It's actually not. It's not necessarily true. There's a wonderful book came out in 2020 that it's hard to read, but it's really important. It's called The Big Myth. It was written by Naomi Oreskes and a colleague in California. Oreskes is a professor of history at Harvard. The big myth is the myth that competition creates improvement. The big myth is the myth that markets are essential to freedom and thriving. This myth, in her book, she traces the source of it. It goes back to the 1930s and the 1920s, and eventually the Chicago School of Economics. And it was very well supported by moneyed interests, so that they actually quite consciously convinced Americans read the book. It's really kind of interesting that competition and freedom are connected. They're not. And Oresky shows how the connection is, if anything, unproven and probably disproven. And there are plenty of countries that, have a different ethos, like, cooperation is better than competition. Mm-hmm. My own view, for the record, is that the competition is, on the whole, I'm not sure it's generated the improvements that we really need or want. It tends to produce overproduction, people that produce too much, failures of cooperation, so that, I remember speaking to a hospital about a very important project they did to improve care for congestive heart failure a number of years ago. I said, gee, tell me about it so we can publish it. They said, no, it's competitive advantage. For Pete's sake, I think cooperation beats competition most of the time. And you can see it in the VA, for example. Lots of innovation comes out of the Veterans Health Administration, tons of it. They were the leaders in patient safety when the safety movement began, because they are highly systems oriented. So I'm not sure I buy the first premise, mm-hmm. that competition is the source of innovation. Mm-hmm. I don't think so. Sometimes. In the pharmaceutical industry, maybe, because that's been a very, very productive industry in getting us good new stuff. But it's also produced a lot of junk stuff that's just doesn't make any difference at all, and they sell it. So we could talk about that for the rest of the time. Yeah. Now let's say you are a believer. You say no, competition is the American way. Well, a single payer doesn't do away with competition. If out there it's the same system, single payer can use incentives to actually reward places that are making progress. It also can insist on sharing knowledge. We actually did that in CMS. We had a project when I was there on patient safety. It was called Partnership for Patients, and it was funded out of the Affordable Care Act's Center for Medicare and Medicaid Innovation, CMMI. And we decided to create a $1 billion pool to encourage all the hospitals in America to improve patient safety mm-hmm. under certain kinds of patient safety. The response was overwhelming. I think when we announced that program, most of the hospitals in America decided to do it. We had published metrics of the gains made in hospital-acquired infections and readmission rates. There was a reward system. So the hospitals that actually made more gains against hospital-acquired infections, they got a little more money. I mean, it unleashed a lot of energy, I must admit, against my own interests, that when you put the money on the table, they went for it. So, we could use a single-payer system to encourage competition if we really believe in it, or to encourage cooperation, or to encourage transparency. Once you have a single payer that's got the public interest as its only motive, not returns to shareholders or payment to private equity, once it's we're here for the public, you can use the tools of the market better to lead to the improvements we're after, Chethan.
Well said. Yeah. And it allows you to, as you've mentioned, align budgeting as well for the public interest, right? You've talked a little bit about that. You've called it was it global, what was it, global community budget? Or it was global budgeting.
No, you can, right now we pay mostly for events like, doing an MRI, we being both the commercial insurers and the government. We also pay for admissions. That's the DRG system in Medicare, in which you get paid a certain amount for taking care of a heart attack. What we don't pay for is whole system performance, everybody working together to make sure that Chethan gets all the care he needs, no matter where he is. A single payer system stands a chance of payment that's more global or more organized around the needs of the patient instead of keeping the machines going. And I think that can be better. It could be worse. Let's be clear. A single payer system doesn't mean you don't need to use your brain anymore. You have to think really hard and use a lot of, I think, innovation, what do I call it? Exploration, learning. You say, that didn't work. We tried this payment thing and no, that didn't work. You got to be able to change and learn. The other thing about single payer, I'll say, just because it occurs to me it's important, is the only reasonable single payer system I can think of is governmental. Maybe there'd be a way to set up some private corporation that manages payment under government surveillance. And there are a lot of models in other countries for different payment that isn't quite single payer, but it's government accountable payment. And we leave that alone. Once it's government, there are lobbyists. And that's true. In Medicare, there are people in my office every day demanding more money or demanding that I lighten up on some regulation. So a single payer system, if it's governmental, becomes more subject to the phone call from a congressman or a lobbyist. So in some ways, this sounds like a really big stretch. I personally think we may need to link single payer healthcare to campaign finance reform. That sounds like a stretch, doesn't it? But we have to somehow insulate a government single payer to some important extent from the phone call from the lobbyist who said, pay my donor more. And it's a little bit risky here. On the whole, I'd still take it. I think it's better. And if it's probably done, it would be transparent. But I don't want to say that's not a problem. It is.
Yeah. No, I don't think that's a crazy idea at all. I mean, I think, especially nowadays, I mean, it seems as though a lot of folks view healthcare as very muddy waters. There's a sense of distrust, right? I mean, who's lobbying that? Who's lobbying that? So I think actually being proactive on that side is important. And I think if done right, I mean, certainly really resonates with me. And articulating the needs of all Americans, right? At the end of the day, I mean, like we said, I mean, everyone's going to have a different need. And I think even from a budgetary standpoint, I love the points you raised, because if you think about efficient budgets, don't they tailor those to areas of higher need and trying to produce the best outcomes for the overall group?
The current system does the opposite.
Exactly.
Look, sorry to tell you, if you haven't heard the news, the rich get richer. Especially in a country where you can use wealth to donate to political candidates who then have your interests in mind. So the current campaign finance system, for example, it's socially regressive. You can be pretty sure that people with the most money will have the most political clout, and people with the least money will have the least political clout. Play that over into healthcare, then you'll find healthcare attending to the needs of wealthy people. Hospital systems that make sure that they build their next hospital in a wealthy suburb instead of a desperately poor urban area. So we've kind of got the system rigged for regressive financing. Resources flow to the wealthy. In a single payer system, I hope, especially if it's governmental, it's accountable to everybody. And I might even say, especially to people in circumstances that make them sicker because they're in a poorer context, a poorer area. So we get a chance with a single payer to help the people that need the help the most. The market system we have now and a multi-payer system, no, it doesn't really do that.
Yeah, I agree. So what do you look at, with what's currently happening with CMS? There's new initiatives out there, right? Rural health transformation. We recently had Abe Sutton from CMMI on this podcast as well. We've talked to Mark Cuban recently about his drug pricing transparency projects. He's partnering with CMS. What are the things right now that you're seeing that excite you, and what are the things that concern you?
What Donald Trump and his administration are doing is the most harmful to American health, certainly in my lifetime, of any government, probably historically. They're cutting back on the very supports people need to stay healthy. In their failure to continue the premium tax credits in Medicare, they're going to strip coverage from millions of Americans. Their support of anti-scientific bad science, they're really, really hurting health. And CMS is part of that administration. Now, Abe Sutton and others, I think there are people in CMS trying to find an avenue, a window for some improvements that make some sense. But this tendency to support the rich, to yield to lobbyists, to not honor the science, not make sure the poor are protected is just toxic. Some of what CMS is trying to do with payment innovations is worth exploring in any administration. But on the whole, I'm very worried that it's just part of the action to take money out of people's pockets and to support the rich. I hope that's not true. And by the way, within CMS, there still are some hardworking staff who've been there and remaining there for their careers. Right now, they're very, very demoralized because so much of the action goes in the wrong direction. They want a stronger Medicaid system, not a weaker one. They want Medicare to be working on quality, not on pricing games. So, but they're still there, and I think they still try to do good work. So it's a bit of a mixed bag. Overall, though, this administration, to call it an utter failure in protecting American health is an understatement.
Yeah. Yeah. I mean, there's a natural tension of, new initiatives and innovation, but if you are cutting funds, I mean, how do people even get that care in the first place?
Yeah, cutting funds for the poor. I mean, that's just absurd. Guess what? They're going to get sicker. Then you're going to have to pay anyway. Yeah. And you, by the way, may not be the federal government. It may be the states, because there's this actual shift of burden to states. It's just ridiculous. The innovations that are, you mentioned pharmaceuticals. There are, if we can keep it going, there are some innovations like drug price negotiation, what Mark Cuban has been doing.
Yep.
Yes, that's good. There seems to be some political force behind getting the drug companies back in order in terms of their profiteering, excessive profiteering. So maybe that's one little light in a very dark terrain right now.
Yeah. Mark Cuban was talking about that and just how that collaboration has kind of grown a little bit with time, particularly for him and CMS. What are your thoughts on the rural health transformation initiative? Do you think, I mean, I know you're passionate about rural health. You grew up in a rural community. Is this a step in the right direction?
Yeah. Well, first, remember the context was this big, beautiful bill, which is as bad a bill as has ever been passed. And so in order to make the politics come out right, they put this SOP in it to give some money to rural health. That's good, but it's nothing like what rural health needs. It's a pittance compared to what's going to be needed to actually boost rural health to the level it can be. It's a good thing to do to make sure that resources, and by the way, information technology resources flow to rural areas. So I'd say a little bit of the right stuff in a terrain which is going quite the wrong way.
So what, Don, right now, what keeps you, or if you are, I mean, are there things that make you optimistic right now?
Yes. Yeah. I mean, in the United States, innovative islands, places that are doing stuff that really, really is good. I would put Northwell on that list. There's just so many innovations come out of that organization. And there are other organizations that are doing good things with chronic illness, continuity, with proper uses of AI, with cooperative efforts with communities. And piece by piece, there's always bright lights in America. But no, the lights are quite dim right now in terms of spreading all of that good stuff and properly controlling healthcare costs instead of just slashing. But there are islands of really positive stuff. In the U.S. and abroad, I'm still moved by the workforce. I mean, doctors are really, and nurses, they're very frustrated today. They know that things are going in the wrong direction, but they're still showing up for work every day and doing beautiful work as best they can in a system increasingly broken. I would say also in the U.S., there is more political dialogue now. For example, private equity and its damage to healthcare is under bipartisan scrutiny now in Congress, and as are drug prices. So I think there's some effort to push back on this lobbying. I get a lot of my boost internationally. It's always dangerous to say it because now people start accusing me of being whatever, a communist or unloyal. I'm neither. But I just came back from Norway looking at some really interesting stuff going on there. On rural health, by the way, Norway has areas that are pretty far from any urban areas. How are they going to make sure that they're guaranteeing proper care for those rural areas? That's a very active area of innovation and commitment in that country. Denmark's done some great stuff on regulation, really, really interesting modifications to the regulatory environment, really freeing hospitals and healthcare systems to do more on their own initiative. I think what's going on in Singapore on trying to figure out better ways to take care of people with chronic illness. It's a big, big issue. In Taiwan, they're working on elder care. So as I go around the world and look at these systems, none are perfect, all have problems, but I find these really quite brilliant designs that yes, could use tomorrow. We could say, hey, great idea. Let's use it. We don't actually tend to do that very much, but it cheers me up. I can see, oh, we really can do things together as human beings.
Yeah, and you open your eyes to the incredible innovations that are happening across the world.
Interestingly, that includes developing countries. Like I just was in Nigeria,
yes, huge.
which is, I mean, it's a big country. They got a lot of problems, but they know it, and they're smart as blazes, and they're working on innovations and care to kind of get on top of some of the very severe issues that they face. Ghana has done a tremendous piece of work on improving the healthcare of kids under 5. That is, it's just terrific. South Africa works on HIV/AIDS care with innovations that we haven't even tried. So, and birthing. There's a project right now in Brazil on safer birthing that has had already phenomenal results. So we can learn from everybody.
Absolutely. And I certainly hope that, I think one thing that many of us think about are some of the regulations that were rolled back during COVID. For example, the upcoming telehealth cliff, right, in 2027. I mean, are those things going to go away? Are those regulations actually going to come back and prevent us from continuing to innovate? I think that's a major concern. I don't know if you have thoughts on that.
Yeah, my thoughts are the same as yours. It's a major concern. The telehealth is now a really powerful potential solution to our staffing shortages, to our commitment to excellence, even in rural areas. You can get the best care to an isolated rural area through telehealth today. Absolutely. And I actually did that. I worked in the Indian Health Service in Alaska as a pediatrician when my wife took a sabbatical in Alaska. And so I would fly out occasionally to tiny Eskimo villages on the Bering Sea coast, let's say, hundreds of miles from even a small town. And I fly in, and the health aide in the town would have stacked up a bunch of kids who needed the attention of a pediatrician. And for a couple of days, I'd work my way through that list. If I ran then into a complex issue, I had a telehealth connection automatically to the tertiary hospital in Anchorage, and we could solve the problem on the spot. I actually thought the access to specialty care in Scammon Bay, Alaska, was faster and better than in Boston.
Wow!
Because in Boston, I would have to wait to see a specialist. Yeah. In Scammon Bay, the specialist is right there. So they've been pushing the envelope on telehealth for years, and it's wonderful. But it takes legal. It has to be legal.
It does. No, it's so true. I mean, there's so much care that we can offer in a tech-enabled fashion. Telehealth, wearables. You don't need necessarily that bricks and mortar initial interaction. I mean, you eventually might, but there's so many inefficiencies there, and I think that's such a great example.
At some risk, I'll say you don't even need doctors sometimes.
Yeah, I agree.
A combination of telehealth and the a local community health worker or more advanced physician assistant, you can get top-notch care. Yep. Alaska also pioneered in a group called Advanced Care Dental Hygienists. These are they're not dentists, but they're hygienists trained up in a 3-year program to do a lot of the care that is reserved for dentists. That was the system I worked with in Alaska. It meant that they could get really advanced dental care to very small communities without having to have a ton of new dentists. The Alaska Dental Society didn't like it at first, but they eventually approved it. And man, it's a terrific system. But it's blocked in a lot of American states now because the dentists fear it'll take, I guess, it'd be worse care or take money out of their pockets. We actually have great research showing that system produces better care at lower cost. So we have to, that's a mental model block. It's not technical.
Yeah. I mean, at the end of the day, I mean, the example you're giving, I mean, it's about rethinking workflow too, right? We can't practice the same way we used to practice.
That's a great phrase, rethinking workflows. Yeah. And then, giving up a lot of the assumptions you come in with and saying, maybe there's a better way. And I'll tell you what, there is.
Yeah. Don, you're such a humble, incredible leader. You've had such an impact on so many individuals, as I mentioned, and you've had such incredible, impactful work throughout the years. Is there one main thing that, and there's many, I know, but is there one thing that you look back on and you say, hey, listen, I mean, this really helped move the needle on quality of care as it stands today that you were leading? And I know there's many.
It's kind of a trick question because you added that I'm leading. I actually, and I don't often feel that I'm leading. I feel like I'm joining or following. The example that occurs to me in response is the 100,000 Lives campaign. That was the idea that we had a number of changes which we knew could help save lives in hospitals. They weren't like nailed down to New England Journal standards, but we had enough, IHI, we'd had enough experience. We knew that this stuff was good stuff. So I guess I thought of it, but immediately we had a group formed to think about the changes. There were 6, and then this little task force established under the leadership of my much admired colleague, Joe McCann. They converted it into a campaign, almost a political campaign, which we called the 100,000 Lives campaign, in which we proposed to save 100,000 lives in 18 months by enlisting hospitals and making those 6 changes. I mean, it was probably the wildest ride of my career. We had 3,300 hospitals within 6 months signed up. We had activities all over the United States and replicas in other countries. Japan started one. I think there was one in Wales. And we don't actually know how many lives were saved. It's very hard to track it all, but I'm pretty sure tens of thousands of lives were saved with these changes all over the country. And in 18 months, we were able to celebrate tremendous success. I didn't lead it. Maybe I triggered it or something, but it was this incredible group of people all over the country just coming together with their hearts in their hands, making the changes. It was really probably the best technical experience I've had in the world of improvement. We could do it again and again if we wanted.
Such a good example. And public health at its best, which is a huge team sport, right? Takes many, many folks.
Yeah, we don't need the heroes. We need everybody just to do.
Absolutely.
Enabled to do what they want to do.
Yeah. And that's why your points about community health workers, frontline workers, right? I mean, that's where the change is going to happen. And how can we support them with respect to infrastructure? So, Don, thank you for spending so much time with me. Continues to be a pleasure to follow all the incredible things you're doing. And we really do appreciate it.
Thank you, Chethan. It's a pleasure to join you, and thanks for the work you're doing.
You too. Have a great day.